So I'd like to take this opportunity to introduce Dr. Pippa Hawley, who will be presenting this morning on the Bowtie model, early integration of palliative care. Dr. Hawley is the medical leader of the Provincial Pain and Symptom Management Program here at the BC Cancer Agency, in addition to the division head of palliative care at the UBC Faculty of Medicine. And I think at this point, I'm going to hand it off to our speaker, and she can go ahead.
Okay, thank you very much. And can I just confirm that everyone can hear me okay? I don't know if it's possible, somebody in Toronto, to just make sure that the sound system is working okay?
Yes, we hear you. Thank you.
Okay. So thank you very much for inviting me to do this presentation. I know that survivorship and palliative care sometimes don't get thought of in the same breath, but what I'm hoping to do today is to convince you that we are actually all doing the same thing, and we need to communicate with our colleagues, our patients and their families about the importance of integrating palliative care into cancer care early on, including at a time when survivorship is still a possibility. So I don't have any conflicts of interest to declare. I guess the only benefit of earlier integration is I'd have more work to do, but I'm already working 50 hours a week, so I can't do any more. So I don't think I have any conflicts here. So my objectives here are just to explain to everybody how preconceived ideas about palliative care need to be changed, and I don't want to be preaching to the converted. This is about giving you tools to be able to understand it yourself, but more importantly, to explain it to other people. One of the ways of being able to do this is visually. So I'm going to show you the Bowtie model, which is pretty simple and I think illustrates what I'm going to be covering. And there's a little bit more just general information about having a strategy for overcoming the resistance to acceptance of palliative care because of its association with death and dying. So first of all, looking at the historical understanding of palliative care, originally when palliative care was kind of invented, it was really end-of-life care. The word, actually, palliative care started out by Balfamount in the Royal Victoria Hospital in Montreal, because in French, the word hospice was associated with lepers and the destitute, not the dying. So when the first hospices were created in the Francophone language and culture, there was a sort of pejorative opinion about that. So Bal came up with the soins palliatifs for palliative care term, which has now become the international kind of terminology that's accepted. But people felt that at the beginning, palliative care and hospice were synonymous, and that you would go through your course of illness having the focus of care being entirely active or curative intent, till at some point you hit a black line. There's a point where someone says, okay, no longer curable, and now we're just going to focus on keeping you comfortable. Basically, Shackleton's not coming, you're going to die from this. And over time, there's been modifications to that. The Canadian Hospice Palliative Care Association model, which was originally put out in around 2000, so we're talking 15 years ago, their idea was that it shouldn't be an all or nothing thing, that you have this graduation in focus, a change of focus of care. So at the beginning, your focus is, obviously, the vast majority of it is to modify the disease, so right at the beginning here. And then as time goes by, once the focus on there's a sensitive pad here. Let me just go back again. As you go through the disease, the focus being more palliative care tends to increase, but there's still only one way out. It's still you're going to die, and bereavement is the only exit route to this model. This supposedly new model has actually had a glacial rate of uptake, even though in the literature you can find it very widespread. Even looking at ASCO only 5 years ago, this was being put out there as a proposed care model by Jennifer Temmel, who was one of the authors, actually the lead author of a seminal study done in metastatic lung cancer patients at the Mass General, which showed that people who had early access to palliative care lived longer with a degree of magnitude that was equivalent to palliative chemotherapies, which were considered an absolute slam dunk that have to be funded. So you think, well, 2010 years later, the Americans, it's supposed to be the most up-to-date leading cancer care organization in the world, are still thinking that this might actually be a good idea. if you look on Google, say if I was a patient and somebody was talking about palliative care, if I did palliative care and then did Google Images, these are some of the things that come up. I mean, this one is essentially just a rehash of the CHPCA model just to make it look a little bit prettier and to indicate that the component of palliative care as compared with disease-modifying treatment tends to fluctuate, and that people can have crises which they get through and then they become more active treatment, whereas different chemotherapies or radiotherapy or whatever comes along. But at the end of the day, there's still this biological death. I'm not sure what is an unbiological death, but it's in there. It's still the only option here is bereavement. This is another one which I found which is particularly scary. I mean, this is in the top page of the Google Images search. You know, it's terrifying. If you were a patient and you looked at this, you know, you see that person in the wheelchair that's disappearing, and eventually at the end of the marginalization, you end up a speck on the horizon. It's really not nice at all. It looks a bit like one of those mazes that rats have to run around in. This is another one which I actually liked a little better in terms of the message that it was trying to portray. But if you look again, apart from looking very much like a cigarette, it also has death in big black letters, you know, and then bereavement, continual bereavement, emphasized all the way through. So even though the idea is nice, that you have this idea of integrating palliative care with curative intent treatment, it's still an absolutely terrifying prospect for somebody who doesn't really know anything about this. So what I'm going to just go through now is the current WHO definition, which a lot of people may not be aware of, actually changed in 2013, and it was a subtle change, but a very significant change from a survivorship perspective. And I don't believe that that most physicians are aware of this, let alone most patients and families, or other caregivers like nurses, social workers, physiotherapists, pharmacists, etc. So palliative care is an approach, so key that it's not considered something that happens in a certain place administered by a certain group of people. Palliative care occurs in the setting where the patient is, whether it's at home, on a cruise to Hawaii, in a palliative care unit, on an acute oncology ward, in a surgical ward. So palliative care is an approach. The focus is on quality of life. As you know, it's always the patient and the families being the unit of care. And then we get to the big change, which is life-threatening. It used to be life-limiting. So prevention and relief of suffering, important components, early identification, assessment and treatment of physical, psychosocial and spiritual problems. So I think people know what the services that are provided are. It's the question of eligibility for palliative care and where it's appropriate that the WHO decided needed to be changed. So just a little bit more detail about what palliative care is. Again, I'm assuming I have a pretty well-educated audience here who don't need to go through this in great detail, but I thought it is worthy of just listing there, just in case there are people who aren't familiar with how it works. I wasn't sure where people were going to be coming from when they were attending this webinar. The last part is that the palliative care is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life. And this is not my words, this is WHO's words. Okay, so chemotherapy, radiotherapy, palliative care can be run concurrently with those or other disease-modifying treatments. And it includes those investigations needed to better understand and manage distress and clinical complications. So, for example, you know, measuring people's calcium if they come in with delirium. You don't just manage the delirium, you also manage their underlying disease. You try to correct the hypercalcemia, which may be because, you know, affected by disease control. That's just one example, but there's a number of other situations where disease management actually does affect improvement in quality of life, and therefore they shouldn't be mutually exclusive. So when you actually talk to patients who have serious illnesses, what they want, this is the results of a Canadian study, but it agrees very much with an American study done by the Center to Advance Palliative Care. Of course, they say a cure would be nice. Everybody, that's the first thing. But pain and symptom management is always top. Avoidance of inappropriate prolongation of the dying process is something that surprisingly comes up way more commonly than you think. A sense of control, Not being a burden on family, which is particularly important when we're talking about the Canadian shift to legalization of physician-assisted dying, which is coming and may well be present in places where the people on the webinar are already working. Strengthening relationships with loved ones, so making sure that the focus is on communication, and having honest communication with physicians. People don't want false hope. Though physicians may sometimes think that taking away hope by being realistic is harming patients, patients actually perceive that if they are given false hope, that is harmful. And I've personally had experience with a number of relatives of patients with cancer who've died, who felt that they were misled and they really didn't see a death coming, and felt cheated of opportunities to do things that they would have liked to have done if they'd been aware earlier. So if you kind of really drill down to what we try to do on a day-to-day basis, like what I think I'm going to do for the day when I go to work in the morning, number one is obviously relieving physical and emotional suffering. That's the number one focus of what I'm planning on doing. In order to do that, you have to have really good communication, particularly between the patients and physicians, but also with other healthcare providers and family members. And I'm working not in isolation. I'm very much working in a team. And here in my work at the Cancer Agency, I've got my team within the Cancer Agency, so the patients, oncologists, the patient family counseling representatives, the nurses, but also the teams in the community to make sure that people get appropriate care when they're not in the hospital. So if you actually look at that as a non-specialist, shouldn't everybody get that? Like, what's so special about that? We should all have access to good pain and symptom management. We should all have effective communication. We should all be able to expect that our care is coordinated across the settings. So if you think about it, well, why is palliative care any different to what everybody else should be doing? If you actually look at the studies, though, there are benefits from specialist palliative care. The assumption that you're going to get that type of care without having specialist intervention is not a slam dunk. It really isn't. We know that compared with routine care, you get a reduction in symptom burden for patients. You have improved patient and family satisfaction. You actually have improved physician satisfaction. So the oncologists who are caring for the patients, when they know they're supported by a good palliative care team, actually go home at the end of the day feeling more satisfied with their daily work, which reduces physician burnout, which obviously has huge implications for the healthcare system in retaining our excellent, highly expensively trained oncologists. The big thing that's attracting a lot of attention, particularly in the US, because they have such marvelous financial databases, even though their healthcare system is very expensive, because it's very expensive, every single Band-Aid is counted, and you can track everything. The fact that you can demonstrate reduced cost is huge, and that's one of the things that's really driving the move in the US for implementation of earlier and more extensive palliative care. And all these benefits have been seen in multiple studies, multiple countries, multiple settings. So it's not something we can say, well, it was only the Mass General where this happened in lung cancer patients. We now know it's across the board. And one of the things that the Mass General study particularly was important in showing that no harms have been demonstrated. And there's still a widespread perception out there that palliative care is associated with dying, so therefore must accelerate it. And that palliative care is just providing morphine, so therefore morphine must kill people. And it's warped logic. It doesn't make sense, but out there that's how people think when they don't really fully understand the issues. So we've got a lot of these negative preconceptions to be able to overcome. We also know that the earlier in illness that palliative care is provided, the greater not only the clinical benefits, but also the cost savings. So, if this was usual care, then why would these benefits have been shown? And these benefits have been shown even in places who have, really state-of-the-art oncology services with a lot of psychosocial support and a lot of other supportive care services. So actually having something that's labeled palliative care really does make a difference. It's not just hand-holding. I know there are still a lot of people out there who feel that that's what it is, and that like for example, I'm part of the group that review the applications for our palliative care residency program, and we still intermittently get applications from people who are getting near the end of their careers, and they kind of think they want to back off a little bit, and they think, well, I'll just do a little bit of palliative care. They don't realize that it actually takes training. We've had people applying for jobs as working in our pain and symptom management palliative care clinics who are very competent, experienced GPs, but have never done any extra training in palliative care whatsoever, and they think, oh well, it's just oh well, I can do that. It's really not a big deal. So we've got to overcome these misconceptions. This is a little cartoon which I just particularly liked. Hopefully you can read this at the bottom. It says, "There's no easy way I can tell you this, so I'm sending you to someone who can." So it shouldn't just be a cop-out where the oncologist decides that they don't like having those difficult conversations, so they're going to send them to somebody else who can. But it is important that we register and we understand that communication about death and dying can be very stressful for oncologists, and we need to do our very best to support them in making them feel comfortable and confident in doing this. So just a little bit more about palliative medicine. This is turning out to be really a full specialty now. For example, the Oxford textbook of medicine, palliative medicine, it started out being just a little slim paperback. Now it's almost big as the actual Oxford textbook of medicine, one volume. It's got multiple contributors, tons of chapters, and they're producing new editions very regularly because things change so fast. In Canada, we're having the new 2-year subspecialty, which is going to be coming out soon. We're not sure we're going to quite make 2016, but almost certainly 2017. So palliative medicine specialists will have had the same, if not more, training than oncologists very soon in their specialty. At the moment, we have just a 1-year specialty in Canada, which is going to continue for family doctors, but for Royal College specialties, it's going to be a 2-year program. It's a possibility that there may be an entry route for family doctors into that, but that will require some extra training. So now just looking at some numbers, I've got some statistics here from BC, which I'm going to present to you, and I think they're very representative over the country. But if you look at all the people who are going to die in Canada, there's absolutely no possible way that all patients facing a serious illness are going to be able to receive specialist palliative care. But we already don't have enough warm bodies to be able to handle the burden of disease that we have already. And in actual fact, it's probably not necessary for many of them to receive specialist palliative care, even though we know it's better than regular care. We have to be pragmatic about this and try and make sure that those that need it the most, the ones who have the most serious and complicated issues, are seen by the specialists, but the other people involved in care are capable to deliver the palliative approach to at least the basic level. Palliative care is not just delivered in cancer centers. It's not just cancer that people die from. We have to be aware that actually we need to get right out of the cancer centers and support our colleagues in the non-cancer world and also in settings other than oncology. So we need to make sure that they're appropriately trained and supported. And an important part of training is understanding that you need to learn something. If you don't know what you don't know, you're not going to have any motivation to go out and learn it. So we need to use every opportunity to use education for everybody that's working within the system. And I'm sure most of you are familiar with this concept that the primary care deals with the vast bulk of illness, which can be other specialists. So gastroenterologists, surgeons, family doctors, there's a whole swathe of people who are dealing with general medical issues. And then there are some that have secondary level training, maybe the family doctor that's gone on a few courses, maybe the nephrologist who's done the Victoria Hospice course for a week on palliative care, or the surgeon who did a 1-month elective in palliative care during their residency, which is a rare and unusual occurrence. Wonderful when it happens. And then there's the tertiary care where we have the palliative care specialists. But even though this is a sort of a good idea and a nice visual model, we don't actually really know how big each of these tiers are. We don't know where the patients fall in this. And from a healthcare delivery systems point of view, like if you're the Ministry of Health and you're deciding where to put your money, you actually need to know how big all of these triangles are, and this is something that in BC we've been working on as a big data exercise, which I'm going to just describe very briefly before we get to the model. So in Canada, just look at the national statistics. In 2011, 242,000 odd deaths, nearly 30% from cancer. In BC in 2013, which is the best data we have, if you look at the statistics, it's actually very much the same in terms of proportions of deaths, 30.6% from cancer. So I'm sort of making this case that the BC is no different from any other province. So we don't have data from other provinces, but I believe that the data I'm going to show to you does apply wherever you're coming from. So we actually looked at all of the people who died in BC in 2012, and 89% of them as adult deaths. We didn't include children. 89% of the adult deaths were from chronic conditions, things like cancer, COPD, heart failure, that sort of thing. And what we tried to do is divide up the deaths according to that triangle that I just showed you. So palliative care group A, which is this dark blue group, the people who received one or more primary palliative care service. So these are people who are registered in the system somewhere, either because they were on the BC Palliative Drug Benefit Program, or they'd had some kind of code applied to them when they were in hospital or discharged from hospital. So they're in the system somewhere, but as far as we could tell, had not received any actual palliative care services. And then we go to palliative care group B. These are people who received one or more intermediate palliative care service. So this might be somebody who was on a surgical ward, was discharged, having had a palliative care consult during their admission, but subsequently no specialist care. And then palliative care group C, is the people that actually had a tertiary palliative care service. And when I say tertiary, that means a home hospice consult, admission to a palliative care unit, care being delivered in a residential hospice, and that is at any point. So it could be somebody who was admitted and died 2 hours later on the palliative care unit. They're still counted as having received tertiary palliative care service. So remember, we may be not, just because somebody received the service didn't mean they received service optimally, but really that was the only kind of flag we had. At least they were in the system somewhere. And when we looked at the whole number of deaths, actually, if you add all of those up, that was only 60% of the people that died. 40% of people that died from chronic conditions had no actual footprint in the system at all. This is a large proportion of our citizens who would have benefited from some kind of palliative care service. So if you look at the numbers of the ones who did receive specialist support, 60% of them were just basic registration, 15% of them got a degree of extra support, and 25% of that 60% received specialist care. So if you add that up across the board, 15% of the people who might have benefited from palliative care are those people that didn't die from suicide or road traffic accidents, overdoses, those kinds of things. And you can argue that maybe some of them ought to have had palliative care, depending on how it was coded on the death certificate. 15% of people actually accessed palliative care at a specialist level in BC in 2012. And I suspect that that's probably as good as, or if not better than, some other provinces in Canada. But you know what, maybe that's okay. Maybe that's as good as it gets, and maybe that's what we're going to be happy with. Maybe just aspiring to get to that 15% would be a very reasonable goal. We really don't know, because we don't have any international standards with which to compare, because the quality indicators are not clearly determined yet. For example, as I mentioned, contact with a specialist service 3 days before death after a prolonged period of intense suffering, it really doesn't indicate that this was satisfactory. And a death at home, if you look at it on paper, people say, oh, you should have more deaths at home, people want to die at home. Well, if you die at home in misery because there's no beds and you can't get in, you don't want to go to emergency because the last time you went in you waited 15 hours, they give you a little envelope with 4 Tylenol 3s in and send you home with no follow-up. You know, that you can't, you have to actually look at meaningful indicators. And so there's a lot of work which we need to do on figuring out what really counts, not what can be counted, and looking at it retrospectively. There's a lot of anecdotal evidence that suggests that many patients who would benefit from palliative care don't receive it. But, at least we have a baseline. So now I'm going to look over how I think we can do better. So going back to our patients, this is really important to taxpayers in BC. The Ministry of Health has this huge provincial end-of-life care action plan, which was released in 2013, and it's coming with some dollars and quite a lot of work through our government. There's a huge amount changing across the country as well. I don't know if anybody has been following the most recent pronouncements by certainly the Liberals and the NDP, both of whom are committing to develop palliative care, but particularly the NDP. They're making it one of their platform flagship things. We've got a lot of problems, though, with how they're going to be able to affect this improvement in access. Of course, you've got the usual availability of beds, which is currently the big focus. Everyone says, oh, we'll just increase the number of beds. They don't realize that having more beds doesn't actually help that much if you don't have qualified staff to go in them, and nobody wants to go in them because they don't think that it's a good idea for them because then they're really not dying. We need more specialists, obviously. We need specialists to be able to educate the generalists, not just to deliver the care. We also need all of the other allied health professions, including nurses. We need access to drugs. We need equipment. People need to have things like hospital beds in the home if they want to die at home. We need to have people not going into hospital because they can't afford to pay for all the stuff they need to be able to die at home, like incontinence pads and dressings. The other issue we need to get across is that we shouldn't have reluctance to refer. And I still, even now, even in the BC Cancer Agency Vancouver Centre, where I've been working since 1997 and have trained nearly all the oncologists, all the ones that are under 50 anyway, we still have occasions where I hear the nurse tell me, over lunch, I was in clinic the other day and there was this patient who was really having a lot of pain, and I said, can I refer her to the pain and symptom management team? And the oncologist said, oh, she's not ready for palliative care yet. We're not there yet. Well, if you've got intractable symptoms, like, when are you ever going to be there? And then there's the reluctance to be referred, and that the oncologist does their absolute darndest to introduce the concepts early, to refer appropriately, and the patient says, I want a different oncologist because this guy just keeps talking about dying all the time and wants to refer me to palliative care. That means he's just given up on me, and they fire their oncologist, even though the oncologist has done a really good job. And I've heard that as well in the last couple of weeks here. So, this is how we think about palliative care. If you look at the CHPCA model, we think, therapy to modify the disease. This is great. People are going to live longer, they're going to feel better, everyone's going to feel nice and nurtured. Hospice palliative care feels that we're going to make everybody feel better, we're going to look after the patients, we're going to look after the families, it's all good, and then when they do die, they're going to have a wonderful life, and the family's not going to be traumatized, and it's all going to be wonderful. But if the patients don't see it like that, this is more what patients see, extra cancer cured. This is what they think when they enter the cancer care system, they're going to get cured of their cancer. And if they end up in hospice palliative care, it's going to be some desolate, lonely place, or place where you get warehoused to die, like an old people's home. Really, the only way out is in a box, and the family are going to be suffering with the bereavement from the loss. So explaining palliative care, people get their information from a variety of different sources. I'm sure a lot of you have seen WIT or Bucket List. If you haven't seen them, I would strongly recommend viewing them for your education as well as because they're really good entertainment. But the movies is huge. The news, there's often articles there which can subtly change public perception. TV shows where you have people going through these experiences. The literature, social media, friends and family have been shown to have far more impact than healthcare professionals. Healthcare professionals come right down at the bottom of the list. This is also a nice little funny cartoon which is just to illustrate the importance of us having these conversations now because of the right to die legislation. Yes, you do have the right to die with dignity, but until then anything goes. It's kind of sad to see that people are actually probably going to legally have better access to assisted dying than they are going to have to palliative care by February of 2016. So we've got a very short timeline to change that. So moving on to the visual, this is a really nice cartoon that I've also found on the internet under Google Images, and I loved it. The idea is that when you have an illness, you have two doors. You've got the curative or the palliative, whereas in reality, it's a double door, and when you open one, the other one opens as well. But I'm not very good as an artist, and there's no way I can draw this quickly. But I can draw this quickly. So this is the bow tie model for 21st century palliative care. And I published this in the Journal of Pain and Symptom Management last year, having tested it out in a variety of other venues just to make sure that it was as meaningful to other people as I found it was to me. And the key part of this is that essentially it's the CHPCA model, but with survivorship added. Just to make it sort of symmetrical. If you kind of made a mirror of image of the CHPCA model and just added the top part, which is the cure as being the goal of care, the supportive care, and then the survivorship. The issue is that for most patients is that when they go into their illness, they still think that they're going to be in the top half, that mirror image part, whereas in reality they may be in the bottom half. By sticking them together, making it seamless, then you're enabling people to get access to appropriate care before they think that they're really dying, which may only be days before death in some cases. So some sound bites that can be useful when you're explaining this to your colleagues and your patients is that palliative care is for living well with cancer and trying to always use the living terminology rather than the dying. It's not a good way to die, it's a good way to live, and that survivorship is part of this whole pink palliative care triangle, this palette of services that include survivorship, includes rehabilitation, it includes supportive care, it includes palliative care unit care, and includes hospice, but all of these are part of the palliative care group of services, including bereavement. The disease management aiming for cure or at least control is integrated with the whole palliative care, the palliative approach to care, right from the time of diagnosis. We need to look after the disease and the rest of you is another one that I find that patients and families particularly like. If they understand that palliative care is kind of looking after everything else, that way even things like physiotherapy, which is seen more as a rehabilitation, nutritional counselling, even access to good information through the library. That's really all part of palliative care if you think about it according to the WHO definition, rather than just end-of-life care. We will always be part of your care team is another important thing to illustrate how the two triangles overlap hugely. If you look at this, the largest actual area of all the spaces within the model is the middle diamond. So that's the integrated bit where everyone's working together. We haven't moved exclusively towards survivorship with care in the community. We haven't moved exclusively to hospice and palliative care units. In terms of illustrating it as a trajectory, you notice it's got the big arrow along the bottom, and it deliberately goes a little bit beyond the bow tie, because you've got a little bit before where we need to have public education so that when they hit the model themselves as an individual, they already have a degree of education about these issues from reading in the media and talking to friends and family, hearing about colleagues, friends, family members who've had experience with a disease like cancer. It really doesn't usually sink home and become personal until you actually have a disease. But if you're at that early point, you can say, well, we think we have a good chance of controlling this disease. In this example, where you've got the "this is you" dot here, just on the control side rather than the cure side, and you can say we're going to be trying our best to manage this disease. And as time goes by, it's going to become clearer whether we're going to be able to cure it or not. If we're not able to cure it, then we have excellent support from our hospice teams and the staff on the palliative care unit. But whilst we're going through this process, we still need to ensure that your care is managed with a palliative approach so that you don't lose out on any opportunities to improve your quality of life, right the way through to then improving your quality of survivorship. I mean, the clinic that I was in yesterday, we had basically 3/4 of our patients with survivorship issues, and this is supposedly a palliative care clinic. This is how you can then use the model if you've introduced it early, as time goes by, you can reorientate people to the sort of the big picture of where they're going with their disease management, to say, okay, things are looking pretty good here. We're heading towards survivorship. I think we might have got this. There's still some issues though we need to deal with. You know, you've still got problems with post-thoracotomy pain. You still have your post-herpetic neuralgia. I know you've got your post-chemotherapy peripheral neuropathy, which needs to be managed. This must have been very stressful for you. How's your marriage going? How are your kids coping? How do you feel about going back to work? These are all the survivorship issues that we need to move into dealing with, at the same time as recognizing that we're still not out of the woods yet. You know, there's still a possibility that this person should suddenly develop brain metastases, have a seizure, and then we know that it's incurable. So you have to be able to deal with this dual existence of potential for cure, but also potential for dying simultaneously. And this is another example. You can say this is what we were looking at before. Unfortunately, things haven't gone quite as well as we'd hoped. We've still, you know, hopefully made a big improvement in your quality of life, but it looks like cure is not an option. So perhaps we need to start talking to our colleagues that are more involved in end-of-life care. You've already had good palliative care, but I think we need to have a specialist now to try and help us with this. You know, I'm a little worried about your pain management. I need some help from people that do this, you know, as a specialist. You can have situations where you can never be certain what will happen. I have a patient who I actually saw yesterday who was fascinating. She had very advanced metastatic colorectal cancer and was, you know, basically learning how to die. She was a very organized lady, a little bit control-orientated, was doing a really good job of it. She was going to have the best death on the planet and was prepared herself, prepared all her family, and then she participated in the POG study, which is Personal Oncogenomics Study, where they take tumor cells and do the genotype, and they look for certain biochemical markers on the cells to look for sensitivity to certain agents. And they found that she had a receptor for a molecule which turned out to be a blood pressure pill. They gave her the blood pressure pill within 5 weeks. When she had her next scan, every single cancer cell that they could detect on the scan was gone. And she's now quite a few months out with absolutely no sign of recurrence of her cancer, still taking her blood pressure pill with really no side effects. So this woman is now really having a tough time because she's got to learn how to live again. And the survivorship issues are hugely challenging for her. She'd actually had surgery for a metastasis in her spine, which has caused a radiculopathy, which is permanent. So we're still dealing with the neuropathic pain. She doesn't want to go back to work. She doesn't have any money. She spent it all. She feels kind of a fraud because she kind of had a living wage and feels like, you know, maybe she misled people, so she feels guilty about that. She put her family and her mother through tremendous suffering thinking she was going to die, and now she's not. So, you know, we can never really be 100% certain what will happen. So once you get people on this trajectory of palliative care, you have to be aware that, you know, survivorship can happen. And in the same vein, survivorship can change. All of a sudden, someone can have had their breast cancer treatment 20 years ago, and then all of a sudden, as I say, they present with acute spinal cord compression or a brain metastasis or a huge stroke, which turns out it's because of a metastasis. So we have to be really aware that this palliative approach to care should be integrated through care all the way along. So I've been trying to go quickly enough so that we have enough time for discussion here. I'm just going to briefly summarize, and we still have 15 minutes, so I'm hoping you can all be thinking about what you want to ask or what comments you'd like to make. I'm hoping that now you understand how modern palliative care has changed, and that we're really in the forefront of the new era of modern palliative care. I'm hoping that you'll be comfortable to draw that bow tie model. I can draw it in about 10 seconds on the back of a napkin. It doesn't take much practice, and you can use it to illustrate how palliative care integrates with cancer management throughout the course of illness. And you can use this as a tool for overcoming patients' and families' reluctance to accept palliative care, but also your colleagues. Use every opportunity to educate people. My kids' friends know about this. My husband, who's a sailing instructor, was teaching a course the other day, and they were chatting about somebody who had a cancer, and they were the people on the course were talking about their perceptions of palliative care, and he said, well, actually, it's not like that. And, all these opportunities, whether they're social or professional, are important because we need to make sure that this message is received, because of the burden of suffering out there is still huge, from cancer as well as other conditions, and people are still missing out on care, which is not that expensive. In fact, is cheaper than the regular care. It's not that difficult. Like, we can deliver this at least a secondary level with really not that much extra training, and we should be taking every opportunity to try to do this. We need to make sure that people are using the vocabulary of palliative care early in the course of illness, so that people understand that palliative care and hospice are no longer synonymous. The Hospice Palliative Care Association, the BC Hospice Palliative Care Association is one. There's the Canadian Hospice Palliative Care Association. We need to make people understand that they use both those words because they want to include it all, not because they're synonymous. If palliative care and hospice were the same, then we wouldn't need to use both of them. We need to be very clear that hospice is only one part of modern palliative care. So that's my presentation. I'd like to stop now and see if Isabel can solicit some comments from our listeners.
Well, thank you so much, Dr. Hawley, for your presentation. That was really wonderful.